Yeah. Morning, everyone. So I'll be continuing the alcoholic liver disease in my topic. So last class we've studied about fatty liver, alcoholic hepatitis, and cirrhosis of liver. So now I'll be talking about complications of cirrhosis of liver. So the most common complications, cirrhosis is portal hypertension, which is the most common cause leading to ascites. So portal hypertension can cause esophageal varices, portal hypertensive gastropathy, splenomegaly, which is the most important sign of portal hypertension, hypersplenism, and ascites, SBP, spontaneous bacterial peritonitis. So it can cause hepatorenal syndrome type 1 as well as type 2, hepatic encephalopathy, hepatopulmonary syndrome, hypertension. Malnutrition can also cause coagulopathies with mainly factor deficiencies, mainly 2, 7, 9, 10, fibrinolysis, thrombocytopenias, bone disease like osteopenia, osteoporosis, osteomalacia, hematological abnormalities, anemia like anemia, hemolysis, thrombocytopenia, or neutropenia. Okay, so these are the most common complications of cirrhosis of liver. So upper GI bleed, it's common in chronic liver disease. It occurs mainly due to portal hypertension. So, and it is more common distal esophagus and proximal stomach. So in the stomach, usually it's around 2 to 3 centimeters below the gastroesophageal junction. So that's how it's very common. It mainly occurs due to portal hypertension. So the most common causes of upper GI bleed. So you have peptic ulcers. If they ask you what is the most common cause of upper GI bleed, it's always peptic ulcers. Peptic ulcer usually caused by NSAIDs or H. pylori. So then you have gastric erosions. The erosions could be due to again NSAIDs or alcohol. Then varices, upper GI bleed, gastroesophageal varices. So that could be due to liver disease or portal vein thrombosis. Uh, and then you have esophagitis. So most common with Hartisania. So occurs in around 10% of the patients. Then other causes include vascular malformations, then aortoduodenal fistula, Mallory stare. Mallory stare mainly occurs to the retching. Okay, so patient, when he has this complaint of retching, suddenly there is a tear. So this presents an acute emergency wherein patient presents with huge amount of blood loss. So it's known as Mallory waist, usually seen on the greater curvature. So here it's seen here. So the most common cause I've already said, peptic ulcer is the most common cause, around 35 to 50% of the it constitutes around 35 to 50%. Then you have gastric erosions, upper GI varices, gastroesophageal varices, esophagitis. Okay. Clinical features: recurrent hematemesis, dark red usually, and that's the most common important clinical feature. Patient may present with giddiness or syncope, okay, and then shock, ascites, renal insufficiencies, okay. So that's how a patient with upper GI will usually present with. So that's due to hypertension. Patient may have giddiness or syncope. So diagnosis, most important is first thing when a patient comes, first check for the vitals and stabilize it, put him oxygen if required, then check all the vitals. Then as soon as possible get one upper GI endoscopy done. So that's the most important part, okay, to look for any varices or the what is the cause, if there is any retching, Mallory waist tear, any erosions. So only upper GI endoscopy is the investigation of choice. So then you do LFT mainly to look for any alcoholic liver disease picture or alcoholic hepatitis, or if the patient has any other disorders, you do LFT. CBP to look for any, to look for hematocrit or thrombocytopenias or anemia. So renal insufficiency, the patient has RFT, to look for RFT. Then coagulation profile also you do to look for any factor deficiencies. Okay, H. pylori test. mainly because because the most common cause is gastritis, peptic ulcer disease. So H. pylori is very important. USG abdominal pelvis to look for any ascites or splenomegaly, hypersplenism. So these are the most important investigations you do when a patient with upper GI bleed comes. So major stigmata you have, you see the active arterial spurting here. So mainly due to gastric ulcer. Okay, it's mainly due to gastric ulcer. So here you have to do an endoscopy and put a clip mainly to stop the bleeding. So prognosis is very poor because near there is arterial bleed. 80% of the cases patient may bleed. Okay, here you can see visible vessel here. Okay, visible vessel. So here hemostasis is mainly achieved mainly after the clip is placed. So emergency management, first thing I have already told, check for the vitals and gain IV access. You put a large bore cannula, okay, at least two on either side, because you need to transfer, if required, transfer some PRCs or even platelets if required. So then check first IV access, then check for the full blood count. The patient is in shock, give him IV fluids, and check the full blood bed count, and then routine biochemistry and coagulation screen. Cross match also you send, cross match blood. Then you perform hourly measurement of blood pressure. You measure BP, pulse, and then urine output as well. Okay. So then you monitor CBP depending on the severity of the bleeding, and also give IV crystalloids in patients with hypertension and tachycardia. Okay. So IV crystalloids are usually given, and transfuse with blood if blood pressure is, the patient is in shock, of the patient if he is actively bleeding, you have to give him transfuse with blood. Okay. Then you plan for endoscopy for diagnosis and treatment once the patient is resuscitated. So that's how you do. Firstly put IV access and then send all the routine investigations, and if the vitals are stable, then you go for an endoscopy. Okay. So then you usually give 72 hours of PPIs, IV infusion for bleeding peptic ulcers. If it is peptic ulcer bleeding, then you have to give a infusion of PPI, usually pantoprazole. So for at least for 72 hours. Okay. Then consider surgery or intervention radiological if bleeding recurs. So treatment of coming to varicose bleed due to cirrhosis of liver. So pharmacological therapy. So mainly you decrease planching blood flow give by giving vasopressin and its analogic. Because there is planchic vasodilatation, to decrease the planchic blood flow, you have to give vasopressin and terlipressin. Terlipressin, it's an analog of vasopressin, or somatostatin and its analogs like octreotide. Okay, give terlipressin and octreotide. Then to decrease intrahepatic resistance, give ARBs, alpha blockers like prazosin and nitrates. Okay. So pharmacological therapy, these two are the most important part of management. So vasopressin and its analogs, and ARBs and alpha blockers. So that's how pathophysics. You have already told there is a splanchnic vasodilatation and increase in angiogenesis, that is new vessel formation leading to gastral varices. So to decrease that, you have to give beta blockers. Okay, beta blockers inhibit this collateral circulation, so it will inhibit the angiogenesis as well. So that's why beta blockers is very effective for prophylactically giving in a patient with these gastroesophageal varices. So, and also varicose ligation sclerotherapy also can be done. The patient has varices, and then giving nitrates, so it will prevent this constriction. Okay, in hepatic circulation, this is in collateral circulation, this is in hepatic circulation. Okay, so hepatic circulation, there is always constriction. To decrease this constriction, give nitrates and ARBs as well as alpha blockers like prazosin. Okay, and also you can go for shunts, surgical and transjugular intrahepatic tips, you call it tips. And in the splanchnic circulation, there is vasodilatation. So you, to decrease that, you give somatostatin analogs, vasopressin analogs like terlipressin, beta blockers and nitrates. Okay. So just remember splanchnic circulation, hepatic circulation, collateral circulation. So beta blockers are a very important form of management for preventing esophageal viruses. So mainly given for prophylaxis. Okay. So coming to non-pharmacological therapy, that's the pharmacological part. Coming to the non-pharmacological part, endoscopic therapy gives sclerotherapy. Sclerotherapy mainly given by giving sodium tetracyl sulfate or ethanolamine oleate. So mainly these are given, and also varicose ligation also needs to be done. Okay, so sclerotherapy and varicose ligation. So that's endoscopic, and non-endoscopic you do a balloon tamponade. So this balloon tamponade is a three-way. It has a esophageal balloon, esophageal aspirate. So one for gastric aspirate and one for gastric balloon. That's clamped. Usually this is clamped. Okay. So this is mainly, you call it as Serkston Blakemore tube. So this is usually done in the acute emergency when the patient is rapidly bleeding. You need to stop it. So it's a temporary procedure to stop the bleeding and shift him for whatever endoscopy you want. Okay. So TIPS is another therapy which is also a temporary. I've already told, because it's not a long term. It's mainly done to before any, if you're planning for liver transplantation. So before that, it's a temporary procedure to just bypass the circulation. You do TIPS. Shunt surgeries is not usually done now. Okay, it was done previously. So if you're suspecting any variceal hemorrhage, you first thing you do is start IV terlipressin and antibiotic prophylaxis, and then you do an urgent upper GI endoscopy. If the varices are present, then if the varices are present, then go for endoscopic therapy with the variceal banding or sclerotherapy. If the varices are absent, then you have to stop terlipressin and treat it as non-varicose. First thing is you have to see if it is due to varicose bleeding or non-varicose bleeding. Varices, if it is varices, then you have to go for beta blockers or endoscopic therapy, varicose banding. Usually banding is done, and also sclerotherapy can be done. If the hemostasis is achieved good enough, then you have to continue terlipressin and at least for 72 hours, and then add a beta blocker for preventing mainly as prophylaxis. So beta blocker is not the primary treatment. Okay, so give terlipressin, vasopressin analog, and beta blocker mainly used for preventing the next bleed. So it is mainly used as a prophylactic drug. So enter the patient into endoscopic banding program to calibrate the varices. So if the hemostasis is not achieved, then you do a further endoscopic therapy or balloon tamponade or emergency TIPS. Okay, that's how it is. So emergency management of bleeding: give IV fluids, mainly colloids. You give colloids mainly to replace the extracellular volume, and then give vasopressors, mainly with terlipressin. It reduces the portal pressure, acute bleeding, and risk of early rebleeding. Okay. Then you give prophylactic antibiotics like cephalosporin IV, mainly to reduce the incidence of SBP, spontaneous bacterial peritonitis. So emergency endoscopy mainly confirms varicose rather than the ulcer bleeding. Then you give a varicose band ligation to stop bleeding. PPI is to prevent peptic ulcers. PPI is mainly given to prevent the peptic ulcers. Phosphate enema or lactulose also can be given to prevent hepatic encephalopathy. Okay. So here, initially patient comes, you have to give for colloids, go for colloids to replace ECF volume, then vasopressin to mainly reduce the portal pressure, some antibiotics, and emergency endoscopy. So SBP, spontaneous infection of the ascitic fluid without any intra-abdominal source. There is no source. So mainly it's the most important complications with cirrhosis of liver patients. So what are the most common organisms causing SBP? Streptococcus viridans or Staph aureus and Enterococcus. So these three are the most important organisms causing SPP. So diagnosis, you do an ascitic fluid analysis with the absolute neutrophil count greater than 250. So absolute neutrophil count will be greater than 250 per microliter. And then treatment, mainly the first drug will be cefotaxime, cephalosporins, and fluoroquinolones. Okay. So the treatment will be around 1 gram IV. If the patient is admitted in patient, so 1 gram IV TID, give for around 5 to 7 days. Okay. Then you can go for fluoroquinolones. You can give for around for the 2 weeks. After you can give weekly 400 mg can be given for all the patients with cirrhosis of liver to prevent future SPPs. So hepatorenal syndrome, so it is defined as functional renal failure, so without any renal pathology. Okay, this is very important. So it is functional renal failure without any renal pathology. So renal, there is no problem with the renal kidney architecture and all. So 10% of the patients with acute liver failure you see hepatorenal syndrome. So diagnostic criteria for hepatorenal syndrome, mainly cirrhosis with ascites, serum creatinine level greater than 1.5, and no or insufficient improvement in serum creatinine levels. So even after 48 hours after diuretic withdrawal and adequate volume expansion with IV albumin. So absence of shock, there should be no shock, no evidence of recent use of nephrotoxic agents, and absence of intrinsic. So mainly, so the cause of the hepatorenal syndrome is not due to some kidney architectural problem. Okay, so you have to rule out all the other causes of renal problems, like if the patient is not using any nephrotoxic or any intrinsic renal disease. So you should rule out before confirming it as hepatorenal syndrome. Okay. So cirrhosis and portal hypertension, the patient has inflammation, bacterial translocation, vasoactive mediators. There is which leads to splanchnic and peripheral vasodilatation. That will lead to decreased effective circulatory volume, decreased blood pressure, and increased cardiac output. Okay, so if the patient has active diarrhea or if you give diuretics, patient has upper GI bleed. This is the most common cause for hepatorenal syndrome, upper GI bleed. Large volume paracentesis without any replacing with albumin, that also can cause. And SBP, spontaneous bacterial peritonitis, sepsis, hepatic dysfunction. Okay, so all these are the most common causes. So all these can lead to increased RAS, renin angiotensin aldosterone system, and SNS activity. That will lead to increased plasma ADH. So that will ultimately leads to, whenever anti hormone is increased, there is always sodium and water retention. That will lead to ascites and hyponatremia. So that will again trigger the renal vasoconstriction, and there will be decrease in GFR. And if you give ACE, ARBs, and NSAIDs, these drugs, that can lead to further reduction in GFR, that will lead to decreased renal perfusion, then hepatorenal syndrome. Okay, so this is the pathophysiology. So mainly this is the most important cause, splanchnic vasodilatation and peripheral vasodilatation. Okay, this is the most important. And then along with that, if the patient has constrictive cardiomyopathies, or if you are giving if you're giving diuretics, so diuretics you don't give in patients with suspecting hepatorenal syndrome or hepatic encephalopathy. Diuretics are contraindicated. And you have to do paracentesis, but make sure you replace it by giving either albumin or FFP, fresh frozen plasma. Without replacing, if you do a large volume paracentesis, patient may land up in hepatic encephalopathy or hepatorenal syndrome. Okay. So this is the most important, splanchnic and peripheral vasodilatation. So you have two types in hepatorenal syndrome, type 1 and type 2. Type 1, mainly there is a rapidly progressive form of renal dysfunction, and prognosis is very poor and unstable. Serum creatinine is always greater than 2.5. Okay, so type 1 has a poor prognosis when compared to type 2. So there is a rapidly progressive form of renal dysfunction and poor prognosis. And type 2, it's slowly progressive than compared to type 1. It has better prognosis, and serum creatinine is always less than 2.5. Okay, so that's the difference between type 1 and type 2. Creatinine is less than 2.5 in type 2, greater than 2.5 in type 1. Prognosis is poor in type 1 and better in type 2. Okay, so treatment, beta blockers, mainly to prevent further upper GI bleed, prophylactic. Then avoid intracellular volume depletion. Okay, avoid nephrotoxic drug, very important. So avoid some drugs like NSAIDs, AC inhibitors, ARBs. So avoid it. Then treatment of the infection, like if the patient has SPP, Gram cephalosporins. Then IV albumin you give at least 1 gram per day initially, around 20 to 60 grams per day. Then give IV terlipressin. Okay, then you have to evaluate for liver transplantation. Okay, so that's how you treat. So beta blockers avoid intracellular volume depletion, and then give him IV albumin or IV terlipressin. So hepatic encephalopathy, it mainly encapsulates a wide array of transient and subtle reversible neurological and psychiatric manifestations, mainly found in patients with chronic liver disease. Okay, so mainly seen in 30 to 50% of the patients with cirrhosis. So there is rise in serum ammonia level. Uh, it's the most important complication of cirrhosis of liver. So investigation of choice is serum ammonia. There is always serum ammonia is raised. So causes, there are some drugs which causes mainly sedatives. So you have to avoid giving sedatives and as well as antidepressants. And dehydration, mainly including diuretics like paracentesis. All these you should avoid. Photosystemic shunting, infection, hypokalemia, constipation, and decreased protein load. That includes GI bleed as well. Okay, so all these you should avoid. Avoid drugs, mainly sedatives or antidepressants, dehydration, photosystemic shunting, infection, hypokalemia, and constipation. Okay, so that's why constipation give him stool softeners to prevent that constipation. Constipation will trigger pathophysiology. So cirrhosis and portal hypertension leads to inflammation, bacterial translocation, vasoactive mediators. So that ultimately leads to splanchnic and peripheral vasodilatation, which leads to photosystemic shunting. So increased photosystemic shunting will trigger increase blood ammonia, serum ammonia levels. That will again cause brain edema, astrocyte swelling, neurotransmitter and receptor alteration by increasing GABA, altered brain glucose metabolism, ultimately leading to hepatic encephalopathy. Okay, so there is increased permeability of blood-brain barrier as well. Okay, so this is very important. And Pathophysiology, mainly splanchnic and vasodilatation, will cause increase in the shunting, that will lead to increase in the ammonia levels. Whenever the ammonia levels are increased, that will cause increased brain edema, astrocyte swelling, and increased brain glucose metabolism. So changes of intellect, personality, emotions, and consciousness with or without neurological signs. You have 4 grades here. So grade 1, grade 2, grade 3, and grade 4. So in grade 1, there is poor concentration, slurred speech, slow mentation, disordered sleep rhythm. In grade 2, there is drowsy but easily arousable, occasional aggressive behavior. The patient is always lethargic. In grade 3 is marked confusion. Patient is drowsy, is sleepy, but he responds to pain and gross orientation. So in grade 4, completely is unresponsive to any even painful stimuli as well, and is completely unconscious. Okay. So these are the grades. So this is the grade 4 where the patient is unconscious. So how do you assess encephalopathy? Mainly the flapping tremors. Patient may have the patient ask the patient to outstretch and dorsiflex, and you look for the patient has this repeated jerky movements. So you call it as flapping tremors. So ask him to, the patient also has this apraxia, constructional apraxia, you call it. So ask him to draw a star, he will draw like this, something like that. So you cannot exactly draw like that. So we call it as constructional apraxia. And you also, there's also a test called number connection test. So you just put a random numbers and ask him to connect everything. So you ask these. Normally you should kind of do it within in less than 30 seconds. The patient may will not able to be doing this. So that's how it is. Number connection test. Diagnosis. Ultimately, you have apart from clinical features, you have EEG. EEG, you see diffuse slowing of alpha waves with development of delta waves. So that's a sign of hepatic encephalopathy. Slowing of the alpha waves with development of delta waves. And I've already told ammonia or arterial ammonia is raised. Treatment, you mainly remove the precipitating causes like dehydration, constipation, avoid giving him drugs. Okay, dietary protein restriction as well. So you restrict the protein and give him lactulose, mainly stool softener to prevent constipation. At least 15 to 30 ml. You have to give 3 times daily. Okay. So and give a rifaximin. The dose is around 400 mg 3 times a day. Okay. All right. Thank you.